Hello, everybody. I'm David Sklar. I'm director of our Office of Interprofessional Continuing Health Education, and I'm also a professor at Arizona State University and College of Health Solutions. And today we're going to be talking about monkeypox, one of the newer and certainly concerning new viruses that are now spreading across the United States. And we will have two professors from the College of Health Solutions who will be providing their expert information to all of you. One is Dr. Alexis Koskan, who is Assistant Professor of Public Health. The other is Professor Dr. LoVecchio, who is our Medical Director for Clinical Research. He's also a physician who works at Valleywise Health and is also a toxicologist. He actually has many areas of expertise, and he'll be talking about some of the clinical issues, and I'll be moderating. Our hope is that we will have about 15 or 20 minutes at the end of the presentations to be able to ask questions and have some responses from our speakers. I also want to give a little bit of a trigger warning. In these talks today, there are going to be some pictures of some of the monkeypox lesions, and if that makes you squeamish, you're warned. So you may want to either turn away from that or not watch. But I think we kind of feel like it is important for people to recognize what these lesions look like, and so there will be some actual pictures. And this is an evolving disease, so what we're going to be showing you is what we know of today, but it may be different in a few weeks or months. All right, next slide. So the first thing I want to mention is that monkeypox has been around, although we now are seeing it as a new disease here in the United States. It has been around in the world for more than 50 years, and there have even been previous outbreaks in the US. And this is just an illustration of the timeline for monkeypox. Next slide. And the places mostly that we identify for monkeypox are countries in Africa, and that's because the virus has spread from primates, from monkeys to humans, and so that's where the primates that have the virus initially come from. Next slide. So it's important to understand that there are a variety of symptoms. It's not just the rash. And they usually crop up about a week to 2 weeks after being exposed. And Dr. LoVecchio will probably go over this in more detail, but they include fever, headache, muscle aches, lymph node swelling, chills, fatigue, and then the rashes, which we're more familiar with. And those evolve over time, and we'll talk some more about that later. Next slide. And again, we'll hear some more about this, so this won't be the only time you'll hear it, but it is a virus, and it will take about a week to 2 weeks before it actually shows up after exposure. And the good thing about that is that it does give some time to get vaccinated after an exposure, because in this particular situation, the vaccination may actually prevent the disease from coming out. It's often self-limited, which means that even if you get the virus, it's probably something that your own body will be able to fight off without any treatment. And for many people, the symptoms are quite mild, and some it can be quite painful. Next slide. And Arizona has experienced, like other parts of the country, an increase in cases, and Dr. LoVecchio will give the latest number. These were the numbers 281 by mid-August. I believe we're now up over 300 or 350. And so we'll hear a little bit more about that from our experts. Next slide. And so now I'm going to introduce Dr. LoVecchio, and he will talk a little bit more about some of the issues related to the prevention, testing, treatment, quarantine, vaccination, as well as Professor Koskan will also raise some questions and answers about those things. And I know for many of us, we're very tired of having to worry about spread of a virus with COVID. Unfortunately, we do have to be aware of this and take steps to try to prevent it. So now I'm going to ask Dr. LoVecchio to continue with our presentation. Dr. LoVecchio.
All right. Thank you, everyone. Thank you, Dr. Sklar, Dr. Koskan, and people behind the scenes, Ms. Rubio. I appreciate it. I'm going to talk a little bit about monkeypox. And for those of you who didn't know, that was a picture of Jaws, which is a great movie Dr. Sklar brought up, and I think it still holds up. So monkeypox, when you hear the name, you say, oh, it's got to be from monkeys. And it turns out that monkeys were just kind of an innocent bystander. And it turns out we really don't know the origin of it, but we do know that monkeys can carry it, prairie dogs, hedgehogs, etc. We do know something very important about it, that the person-to-person contact is the most important way to get it, okay? There's other theories that you might get it from fomites, which, I use the toilet, and then use it shortly afterwards, unlikely. Or if I have it and I'm talking very, very closely into your face and my saliva mixes with yours, unlikely. You need a high concentration for a long time. So basically, the main way to get it is for you to have very, very close contact with somebody who has it. And usually it's with somebody who doesn't have the incubation period, which is the early on period. You have to have the rash. In other words, if you have close contact with somebody who has a rash, they are likely contagious. The incubation period, which is when I get exposed to somebody and I don't have anything yet, is definitely not contagious. I'm not contagious to others. The tricky part is, right after that, when you start to get the prodrome. The prodrome is what I feel before the rash. Basically, I feel like garbage. I feel like a bus hit me, I have a fever, I have chills, maybe my lymph nodes start swelling, and then I start to develop a rash. And that time is a little controversial. But definitely if somebody has a rash and a fever, it's probably best to stay away. And if you don't know a lot about medicine, maybe it's best to kind of talk to your doctor or do a quick e-visit. These lesions are very, very characteristic. So I want to put a lot of people at ease. Unless you're in close contact with somebody who has it, very, very unlikely to get it. In theory, if I have a lot of lesions that are open, that are releasing pus and secretions, and I lay on a sheet, in theory, you can get it if you lay on the same sheet shortly afterwards, okay? So I guess the two take-home messages are, avoid the close contact if somebody has a rash, and kind of clean your sheets if you don't know who used them before you. Okay, next slide. So it's very interesting. I just want to spend a brief moment about these outbreaks in pre-2020, the US cases. And, and I said, oh, wow, it's from, there was in 2003, there was about 50 cases, and there was a couple cases in 2021, et cetera. And then before this talk, little old Valley Wise, the county hospital, I still like to call it county hospital, we had this many cases just last month. So to put it in perspective, I've seen a couple of cases myself, and I actually like to see the people back, especially in the beginning. I didn't really know what was happening, and you get a better understanding when the patient is in front of you. So the main way people got it way back when in 2003 was these pet prairie dogs. And that's what a pet prairie dog looks like. I always thought it was like a dog. I'm not a huge dog person, but it doesn't look like a dog at all. Just kind of named prairie dog. Okay, next slide. These lesions are pretty classic, and they could look like other things, but just remember that when you get these lesions, all of the lesions are the same. And some people say, this looks like herpes, or it could look like chickenpox. And I say, yes, but usually with those, you get some crustaceans, you might get bumps, you might get flat things, which you call macules or papules. In these, they all happen at the same time. So it's a classic thing to look at. If you see somebody with this and they don't have pain, it's very, very unlikely to be monkeypox. Now, if you see somebody with raised lesions like this, before I gave this talk, I would have told you a couple of things it could be. Nowadays, just assume that it's monkeypox. But these things cause so much pain. I saw a guy about 2 weeks ago, and he had a very, very small lesion. I mean, I got up to him very, very close. I couldn't even notice the lesion. It was so small. And he was a very, very big football player type guy who was crying in pain. And I had to give him morphine, which I generally don't give, especially for rashes. He came back to me 2 days later, and about 15 lesions where that first one started, and excruciating pain, excruciating pain. We tried other things like putting it in lidocaine, like a local anesthetic, an anesthetic that your dentist might give you. We tried giving him more morphine, and we almost had to knock him out to get him some pain relief. And this was a legitimate man who, did not abuse drugs. Later on, what we did is did a block to that area. And a block is something where we put the whole area to sleep. Unfortunately, that block goes away, relatively quickly. It went away within the night. But the guy just begged me to get some sleep. I called him up. He said he did better, but it took about 21 days to resolve. And that's another theme, about, a little less than a month or about 21 days. Next slide. In May of 2020, it seemed like, maybe COVID was calming down and the next wave was happening. We say, what have we done wrong that we're getting all of these, viruses attacking us? And the truth of the matter is the world is much more global. There's people that were in the UK, there's people that were in Belgium, and they had these super spreader events, we thought, and they kind of traveled all over the world. And again, it was from people who were in very, very close contact. I think you can kind of trace them back. There were some rave concert events, okay? And then those kind of folks just spread it to other areas of the world, okay? Next one. These demographics are going to change. By the time I made these slides, this becomes old slides because there's more and more cases. And I want to highlight some stuff of what happened in the United States. Here, when we first looked at these, there's 305 cases. This is from the MMWR, really cool journal, cutting edge. And I looked at people who had it, and the great majority of them were men who have sex with men or in very, very close contact. Many of them are unknown, but 99% of them, are 193 out of 195 of those who knew what their exposure was or their contact was. It was men who had very, very close contact with other men. Okay, next slide. I want to bring you up to date now. This is just a short month after. This is only about 3 or 4 days ago. And we see 2022 in the US on September 8th, we had 21,000 cases, okay? 21,000 cases. We look at monkeypox by age, the great majority is kind of like that 31 to 35 age, okay? And when we look at that, the mega centers are kind of California, New York, Florida, Texas seems to be picking up, but we're catching up. Okay. The other thing I'll tell you is that it knows no race or creed, and it's relatively well distributed over races. Okay. Again, it doesn't know your race when you have close contact. The interesting thing that we'll touch upon later, the people who get the vaccine are majority white, and there's a huge issue there that we've seen with COVID that reinvents itself. And then I hope somebody on this call or this talk can do something about it, because I don't know what to do about it, except maybe more education and more of the same. But I wish we can get the word out to others. Next slide. This is a very important slide because it tells us like what the people had. And what the people had, the great majority had rashes. Okay, so these were culture proven. That means that I proved that you have it, okay, by taking the lesion and trying to grow a culture on it. So the great majority had rash and fever. So two things you want to take away. Rash and fever, that's what I worry about. We see things like malaise are pretty high. Malaise is kind of like, I feel tired, I feel weak. Enlarged lymph nodes. If you have large lymph nodes, that's also, something to be very, very concerned about. And pus, I think when these lesions have pus coming out of them, they're very, very contagious. So I want to take you through the lesions. Stage 1 is, usually lasts 1 or 2 days, and it's something called a macule. And macule is very, very flat, okay? In fact, if you rub your finger across it, you can't really feel a bump. Unlike the papule, which is about another 2 or 3 days later, where you feel a bump. And a lot of people call these papules, looks like a pimple. And you notice that they all have the same thing, another recurrent theme. They're all macules, they're all papules, and then they get these vesicles. And these vesicles get larger, and they look like blisters that are filled with clear fluid. But hold on, because in a couple days, they're going to be filled with pus. And in my experience, this is the best way to kind of get a culture. You kind of pop the top off and you kind of get some of the liquid, and we try to do a culture from that. And then over time, close to 2 weeks or so, then it starts to scab over. And when it starts to scab over, you're still contagious, but you're on the road to recovery. But all of these stages, especially the first 4, give these people rip-roaring pain, incredible amounts of pain, which you don't understand until you really see these patients, I literally in tears. Next slide. This is like a little bit of an atypical sort of slides, like kind of zoomed in, but different areas. And I want to bring a highlight to the classic lesions. Some of the classic lesions there are they're umbilicated. And what umbilicated means is they're raised, okay, and then they have a little dot in the middle. They have a little dot or a little point in the middle. And if you look very carefully, a lot of these do have that. Some of them are starting to scab over, okay? But the umbiliculated lesion is very, very characteristic. Next slide. Again, some classic lesions, okay? And I think that they're very, very subtle on others. I think this gentleman there with lots of hair on his chest, you could have missed that, but you wouldn't have missed it if you asked him about pain, and he was obviously complaining of pain in the area. And if you see the finger there, one of the fingers there listed as D, you might have misinterpreted that as just a simple infection, but just be aware in a couple of days, that's going to get worse and he's going to have multiple other ones. Next slide. There is a vaccine available. There's technically 2 vaccines. And the one vaccine that we're going to talk about that's used a little bit more that I would recommend for you if you do need to get vaccinated, but I want to save that for Alexis. This is live vaccine, and it's only for special folks. So next slide. When you look at that slide, people say, oh my God, we don't have any vaccine, we're out of it, et cetera. And I want to highlight something that the government said, hey, this is how many vaccine doses you can get, okay? This, based upon your size, your population, and I assume some risk went into it. And Arizona was allocated 16,433 vials as of September 7th. So that means if we needed 16,433, we could get them. We only requested 11,633, which tells us that we have more vaccine than it takes to vaccinate the people who are at risk, or at least the people who are at risk who are asking for it, okay? Because those other 5 slides are sitting in a national stockpile that we could use as long as we show justification. Next slide. Another thing to put it in perspective is this is 2022, September 9th, so a couple of days ago. We look at confirmed cases in the US and we have about 57,000. Okay, 57,000. You're like, oh my God, that's a lot of cases, etc. Next slide, or next portion of this slide. We see that the total deaths are very, very low. This is not COVID, okay? 18 deaths out of 57,000. So not that many deaths, okay? And I'm sorry, and this was not just in the US, this was globally. You see the outbreak, global outbreak. I don't have the map there. 18 deaths across the world from this new outbreak in 2022. When I first practiced this talk, and yesterday I practiced it, I said, well, the good news is there's been no deaths in the United States. And it turns out there is a death in the United States now. There seemed to be a death in Los Angeles just the day before yesterday. Next slide. So 1 death in the US so far, that's confirmed. Okay, there's a little bit of stuff called pre-exposure prophylaxis. That means that, I think I'm going to be working with monkeypox. I might be working with monkeys and studying them, or I might be studying animals that have it, or I might be working with people that have this, and I'm worried about getting it, so I can take a vaccine to prevent me from getting it. Okay, next slide. And the vaccines have lots of indications and contraindications, okay? And I think the people say, why don't we just vaccinate everybody, okay? And I say to you, well, if we wanted to vaccinate everybody, there's this ACAM 2000 that we could use, okay? Next slide. And the ACAM 2000 is really, really fascinating, okay? If there's any folks out there with gray hair like myself, you'll realize that this has been around for a long time, since 2007, but it's not used for monkeypox. It was used for smallpox, okay? And some of you may have been vaccinated against smallpox, okay? But it seemed like, we made a statement that we've kind of taken care of smallpox and we don't need to vaccinate folks anymore for it. And a lot goes into that decision, but mainly if the side effects are pretty severe and the cases are very, very low, why would you put people at risk? And I just want to show you what you do with this ACAM 2000, which is not the one we use. Alexis is going to talk about the better ones. Is we take this little piece of metal there. It looks like a fork, right? I think it was modeled after the sun devils there, that little fork there, and we pluck it into your skin. We got to break your skin. Now, I dipped it in some solution, okay, of live smallpox, right? Very, very low attenuated live smallpox virus. And I can go too deep, or I can go too superficial. So already you see a user error, okay? Next slide. And this is classically what it looks like. This is a good vaccination, believe it up on top. On day 5, you get this response. Day 10, it gets much worse. And day 14, you got this hole in your arm, okay? And this hole in your arm eventually scars over, and then you become okay. And if you get revaccinated with this ACAM 2000, we see that it's not as profound, the reaction, okay? So again, I wouldn't recommend the ACAM 2000. It's not FDA approved for this, but if worse comes to worse, we might have to use it with the hope that you're going to get some cross immunization with smallpox and monkeypox. Next slide. So there's treatment considerations, and you always got to see not everyone is the same, but there are treatments out there, okay? The best treatment would be prevention, okay? The next best treatment is if you know you're exposed, especially if you're high risk, you should get vaccinated, okay? Next slide. And there are drugs that we can give for that. So patients who are immunosuppressed, you know, HIV, cancers, etc. And it turns out that kids under 8 years of age are at high risk. Now, as far as we know, there's been no kids that have died, obviously not in the United States, okay? And patients with other active skin conditions turns out to be high risk, okay? And I assume that has to do a lot with the co-infection or the sepsis that could occur afterwards. Next slide. Okay, and there is a drug, okay, tacomaviptamat, which I know I pronounced wrong and I apologize. So I like to call it TPOX, okay? And this medication was used to treat smallpox, okay? So I'm going to give you a lecture on all of the studies here, all the studies of TPOX treating monkeypox, okay? We're going to go over all the clinical trials. And that was it. The lecture's over because there are none. 100% experimental, except there is a study in animals, I believe in mice, where they gave this TPOX and they showed that they had antibodies that maybe could fight monkeypox, okay? So there's no real great data on this. And it could only get worse with this because now people are giving TPOX out, maybe not totally necessarily, and now there's resistance to this already, okay? So there's resistance to this. So there's a national stockpile. You can get an IV if you're vomiting, or you can get oral pills. So I would reserve this unless you got, if you got sick or were sure you got exposed. Next slide. And there's other treatments down the pipeline. A lot of them are used for other diseases such as HIV. For example, HIV cytomegalovirus, which is a virus that can attack your eyes. Next slide. I wanted to say thank you. I know I spoke a little fast and enthusiasm. I hopefully think that I made some points that say you're very unlikely to get this. I would still be concerned if somebody has a rash and fever. Okay, remember early on people are not contagious, and there's certain vaccines that you should consider versus others. Alexis, if you want to start, or Dr. Sklar, thank you.
Sure. Thank you, Dr. LoVecchio, and we're really very fortunate to have someone who actually has experience treating this rather rare disease, and that was really helpful. So now we're going to have Professor Koskan talk a little bit about vaccine and vaccine hesitancy. She's actually an expert in several different vaccines, and so she's going to give us some more information about vaccination and about monkeypox.
Absolutely, thanks. Can we go ahead and go to the next slide? Hi, so we'll talk a little bit about monkeypox, what we know about how it spreads, just to kind of take Dr. LoVecchio's presentation a little bit further, some barriers to vaccination, and it's actually not vaccine hesitancy. So what we've seen with COVID-19 and the politicization of public health and science and vaccines is not what we've seen. It's a very different issue that's impacting vaccination and what the US government is doing in response. So next slide, please. So what we know about how monkeypox spreads, we know intimate, prolonged skin-to-skin contact is how it spreads. It's really interesting. I started this morning just making sure I was on top of the news stories, pulled up, Google News and all the different news stories, as well as any Scientific American, Medscape, Mayo Clinic articles that I could possibly find and say, do we know something more about this? And some of the newer articles were saying, it's actually less about skin to skin and it's more about some of the bodily fluids. So direct contact with saliva and with semen. And as Dr. LoVecchio was also mentioning, the fluids from the actual scabs and lesions, not scabs, but the lesions themselves, the monkeypox lesions. So that's some of the highest risk factors is if you're coming in direct contact again with seminal fluids or with saliva, prolonged saliva, and then prolonged exposure to saliva, and also from the fluids that are coming from these lesions, monkeypox lesions. That's some of your highest risk for actually developing or contracting monkeypox. So massage, prolonged kissing, hugging a person with skin-to-skin prolonged intimate contact is generally how monkeypox is spread. Currently, what we know about wrestling, it's not supposed to say resting, but wrestling is that it's considered currently as low risk, but again, it just might not be necessarily as prevalent among, certain student athlete populations. And so we might learn more about the impact of wrestling and the spread of monkeypox the further that this current outbreak is with us. So when someone develops symptoms of monkeypox and have these rashes, they can be contagious anywhere from 2 to 4 weeks as long as they have the rash. So even again, coming in contact with the scab can put you at increased risk for monkeypox. So this morning I was reading information from the CDC and some of their warnings, and they were saying if there are actually things to try to avoid contact with, it's towels, bedding, clothing, fetish gear, sex toys, and even toothbrushes of individuals that are impacted by monkeypox. So again, information from the CDC currently reported. We still don't know if people who are asymptomatic have, and that's something that that researchers are still studying, because this seems to be a different monkeypox outbreak than what people have seen previously or prior years. Respiratory secretions, we're still not sure the extent to which respiratory secretions, contact with urine, contact with feces. We're just not sure if that's how monkeypox spread, but we do know is, again, prolonged intimate skin-to-skin contact and direct contact with these monkeypox lesions. Next slide, please. All right, so you might be asking, why are we at increased risk for all of these animal to human or animal-borne illness? And we've got increased human and wildlife contact due to climate change, globalization and wildlife trade. As Dr. LoVecchio had mentioned, there had been an outbreak. I believe that was the outbreak back in 2003 or 2004 in the United States. It was in the Midwest, where there were prairie dogs that people were adopting as pets, and people actually came in contact with monkeypox virus at the time. As Dr. LoVecchio had mentioned, it's a misnomer. Monkeypox did not originate in monkeys. It most likely originated in small mammals and spread to other species, including monkeys that were exposed in a lab to this virus. But that's how it got its name. It was first discovered in a lab and given that name, monkeypox. I highlighted increased global travel and not vaccinated against smallpox because that's really what's impacted this particular outbreak of monkeypox. Was increased global travel. So we're seeing it in more countries we'd ever seen it before. It used to be isolated to certain African countries, but now there's more global spread due to travel. And then more individuals are not vaccinated against smallpox. Now, does that mean everyone go run out and get vaccinated against smallpox? No. As much as you might think that public health folks can't wait to stick needles in arms, it's not always the case. Public health medical professionals weigh the pros and cons before deciding to have a mass vaccination campaign. First of all, smallpox, which is also that there's cross protection from the smallpox vaccines for monkeypox, was stated as eradicated in 1980. And so there's been no vaccination since then. So unless there had been people just seeing high risk, right? So, but there's still stockpiles of smallpox vaccines. There's also the risk that come along with getting some of the smallpox vaccines was greater than the actual risk of contracting smallpox. So again, it wasn't this public health disaster that we haven't been vaccinated against smallpox. It's just that it wasn't seen as necessary because smallpox had been eradicated in 1980. All right, next slide, please. So the monkeypox vaccines, there are two that are considered available, but only one that is FDA approved and approved for emergency use authorization, and that's the Jynneos vaccine. And so the CDC recommends that you get 2 doses of this vaccine spaced 4 weeks apart. It received emergency use authorization on August 9th of this year. Individuals age 18 and up can get the vaccine injected intradermally. And I'll show you a picture of what that looks like. Under 18 subcutaneously. It's safe for people living with HIV. That was one of the reasons why it's not, why the ACAM 2000 is not FDA approved. It's because it hasn't been proven to be safe for people living with HIV. It's made of a weakened, non-replicating orthopox virus. Oh, and by the way, you might have heard these terms PrEP and PEP before, and that's the pre-exposure prophylaxis and the post-exposure prophylaxis. If you've heard of these terms before, you probably heard it in terms of the use of Truvada for HIV medication, right? For prescribing Truvada, which is an HIV medication, either pre-exposure or post-exposure to help prevent actually developing the virus. And so pre-exposure means you haven't gotten it. Think of your typical vaccine where you get it to protect yourself in the future. And post-exposure is you think you've come in contact, there's that window of time before you start developing symptoms, but you could still get the vaccine to reduce the onset of symptoms. And that's what Dr. Sklar had been mentioning, that it's still safe for you to get a monkeypox virus if you think you've been exposed to help reduce the likelihood of you actually developing symptoms. Next slide, please. So side effects of these vaccines, at the site of injection, you can get firmness or swelling. One thing that people have found troubling is this red bump that can last 1 to 2 weeks. Recently, Dr. Fauci came out and said, hey, if you develop this red bump, it's actually your body's immune response. It's not going to last forever. It'll last 1 to 2 weeks, and your body will resolve it on its own. You might have tenderness, itching, pain, bruising. Only 1 to 10% of the individuals who get the Jynneos vaccine experience fever and chills. But then you can also have muscle ache, fatigue, headache, nausea. Rare, extremely rare, but very serious is if you have an allergic reaction to the vaccine, blurred or tunnel vision, and shortness of breath. And you need to call 911 if you begin developing these symptoms. I wanted to highlight of the ACAM 2000 vaccine. It's unknown if this is experienced by anyone at large scale in the Jynneos vaccine. It's myocarditis, inflammation and lining of the heart, swelling of the brain and spinal cord. Again, incredibly rare, but they were previously reported symptoms, which is why we haven't rushed out to try to vaccinate people with this vaccine or rush out and say everyone needs to get this vaccine. Also because they're specific risks, risk behaviors that, again, put you more at risk for developing monkeypox. It's not like COVID-19 where we were unsure of what was going on and that we knew it was respiratory and even asymptomatic individuals could spread it. It's symptomatic individuals spreading it. It tends to be more intimate, prolonged skin-to-skin contact with seminal fluids and fluids from the monkeypox lesions. Next slide, please. So the best way to help prevent and control the spread of monkeypox is contact tracing. I'm sure you guys have heard of contact tracing because of COVID-19. Find who an individual with monkeypox, who they've come in contact, and work to vaccinate those individuals. Now, why are we taking the approach of ring vaccination? Well, there's actually been somewhat of a short supply of Jynneos vaccine. And so to try to make sure that those at highest risk get vaccinated, this is the method for trying to ensure, again, that we've got enough supply to meet demand. Next slide, please. So why aren't all high-risk individuals getting vaccinated? You might have that question of, well, you know you're high risk, or if you know XYZ, just go get the vaccine. And it's not necessarily this question of Are people anti-vaccine, or are people vaccine hesitant, or do they not believe in science, or do they not believe the vaccine works, or they not if XYZ, right? In this case, there are people who wanted the vaccine and it's taking them time to actually get it. Next slide, please. So the spread of the virus has actually outpaced the vaccine supply. So one of the responses to this problem, next slide, please, is how healthcare providers actually inject patients with the Jynneos vaccine. So the way that they're now administering the vaccine is through intradermal injection. If you see the red arrow pointing down to intradermal, it shows that a vaccine is being administered between layers of the skin of the individual, intradermal, right? So in the dermis. And this actually requires much less of the vaccine to be effective. So only 0.5 milliliters of the vaccine is needed to be administered twice, right? So once at day 1, and then 4 weeks later, you get your second dose of the vaccine. And by using intradermal injection, we've been able to increase the supply of Jynneos vaccine 5-fold. So each vial can now, instead of just having 1 dose in a vial, you can have up to 5 doses in 1 vial, making this more readily available for populations. Next slide, please. The other problem is that significantly more white men who have sex with men receive the vaccine than non-white MSM. And I was looking at, earlier this week, we had a COVID-19 translational team group meeting, and we had Dr. Teresa Cullen come present. She shared this really great article with me about the equity issues related to vaccine distribution. So 50% of the people who've received the vaccine have been white men who have sex with men, 13% have been Black men who have sex with men, 24% Hispanic, 9% Asian Pacific Islander. And so you can see 50% have been administered to white MSM. So one of the questions is, how do we start making sure that this vaccine is more equitably distributed? So next slide. The US government has a US Health Equity Intervention pilot that they're currently engaged. They're currently engaged in administering the vaccine. In this pilot, they're offering over 10,000 vials of the vaccine, or as many as 50,000 doses that are distributed by local officials at 5 different venues. These include high-risk events or events that are considered high risk, such as they've been distributed at Charlotte Pride, Southern Decadence, Pride, Labor Day in Oakland, Atlanta Black Pride, and an event in San Francisco. And it's not necessarily the parade or the event or the festival that's high risk. It's any activity, if anyone engages in any sexual activity after these events or during these events, that healthcare providers and public health officials want to make sure that people are protected. And so these large events are reaching some of the high-risk individuals, but there needs to be more of a community engaged approach to now begin targeting smaller groups of high-risk individuals to make sure they have access to the vaccine. And so that is the current response and to the vaccine shortage, and making sure that there's a more equitable response to distribution of the vaccine. Next slide. I believe that's it. Oh, in case you're interested in podcasts, I love podcasts. I highly recommend Public Health on Call. This podcast will kill you. It's by 2 epidemiologists who present on infectious disease and the AMA COVID-19 update. Here's where you can get more interesting information.
Great. Well, thank you very much, Frank and Alexis. And now we're open to questions. And I know some people already have put some questions into the Q&A. Please add your questions to the Q&A and I will try to get to them. We may not be able to do all of them, but we'll do as many as we can. So first question that I have, and this is for both Alexis and Frank. So I got the smallpox vaccine when I was very young. And the question is, am I now protected from monkeypox because of my getting vaccinated for smallpox many, many years ago?
Well, I think that, like everything else, it kind of depends, but the short answer is you have some degree of protection against that. And it's probably why we're seeing more cases now, is because we don't immunize against smallpox anymore. it's been many, many years for you though, right?
Right, right. So another question here, thanks. Question is, can you get shingles from monkeypox?
Wait, can you get shingles? From
Right.
monkeypox? Well, shingles is a virus, right? It's in the herpes family, and
Yes.
you can't get shingles from monkeypox. It's one of the
So-
things that we try to differentiate the two. You know, they look very, very similar, but
Yeah, but completely different viruses. So you're not going to get shingles from monkeypox, but you know, both of them can give you pain, different kind of pain syndrome. So, but they are different viruses. So there's another question here about the cause of death in the person or people who have died from monkeypox. I don't know if either of you have any information on why they died. I think, Alexis, you may have said something about encephalitis. I know that there was actually a patient that we were aware of over at Valleywise that developed necrotizing fasciitis from a monkeypox lesion, but it was really a complicated, he didn't die as far as I know, but he did get a very severe, could have died from it. But it was really more because it got super infected. So the lesion, he didn't keep it very clean, I guess, and other bacteria got in there. But I don't know, do either of you have any more information about the causes of death of those who have died?
I've just seen the article on encephalitis, and I've also seen that it can cause myocarditis. So wondering if one of the other deaths, this is not something I know, this is just
Yeah, you read about it, and at least that's the suggestion.
We also hear that the people who die are typically very immunosuppressed.
So there are a lot of the people who have HIV or
Malignancies, that kind of stuff.
yeah. Now, another question, this is a little bit complicated, but if the person has a rash already from some other treatment, like for example, Cipro, and they may have been exposed to monkeypox, a low risk exposure, is it advisable to also then vaccinate that person since there are complications related to vaccination? I know this is kind of a complicated clinical scenario, but Dr. LoVecchio, if you were
Sure.
such a patient in the emergency department, how would you approach that?
So I think it's very, very interesting, but if you get the vaccine, it's contraindicated or relatively contraindicated if you have an allergy to ciprofloxacin, gentamicin, and I believe egg products. And then the question becomes, well, my patient's at high risk. Should I give it anyway? And the thought is, at least you hear in chat rooms, so we're quoting chat rooms here, where they say, if the allergy is questionable to the Cipro, for example, the ciprofloxacin, another antibiotic, and they are extremely high risk, then you should probably go for it. Okay, but anything short of that, the risk-benefit ratio is not there because it's very, very unlikely that they're going to die of this.
Yeah.
And if they had an anaphylaxis or something where their breathing pipe, their trachea closed down from the Cipro or the gentamicin, then it makes no sense. Why would you put them at that risk? So it's a risk-benefit thing. If the Cipro allergy was kind of questionable and they are at high risk for getting sick because of they had a very significant exposure to somebody you knew was exposed, then you probably would give it. Other than that, most people are going to say, no, stay away from it.
Okay, good. So another kind of interesting question, how do you differentiate the monkeypox lesions from chickenpox?
Right. So chickenpox lesions usually are like all different stages of it. Like when I get chickenpox, many times it looks flat like a macule, then it might have a papule or kind of like a pimple, and then it has crust. And the classic thing we say is like, oh, they got all three formulations of it. In other words, they have all three of those things at one time. Whereas monkeypox so far seems to start with macules, papules, then those kind of elevated sort of pox-like things. And those pox are pretty classic. Chickenpox might hurt, but monkeypox is going to kill you. It's
monkeypox
hurts like a lot.
Very painful, right? So I think the pain is one of the differentiators. And, again, since someone had a question about shingles or herpes zoster, that is also a painful. So the herpes infections are kind of painful. So you might mistake the pain issue there. They do say that, again, all the lesions should be about the same age. I will say that I did see a patient that I believe did have monkeypox where there was some slight difference in terms of the age of the lesion. So I don't know that it's absolutely perfect.
Right. You're right. It's in general.
What about, so if someone was interested in getting a massage, going for a massage, should they not go for massages at this point for a while?
If you have monkeypox, I think the right thing to do is avoid other people getting it. So you should try to isolate as much as you can. And if you go outside, try to, cover things up. Okay. But if you're getting getting a massage with somebody's hand, it's very, very unlikely that if you have no lesions and they have no lesions, that you're going to get monkeypox in that scenario.
What if you don't know? I mean, you may not know whether they have some lesion under their skin that you can't see and they're giving you a massage.
Well, typically the skin has to have a lesion and it's touching you. So, so you might say, hey, can I look at your hands? Or I prefer if you wear gloves. I don't think that's the worst idea. I'm not a big massage guy, so I'm probably going to get criticized here, but I don't know if you can give a good massage when somebody has gloves on, but we do all sorts of things with gloves on in the hospital.
And from the CDC's website, I got the idea this is more of an intimate massage than a going to Massage Envy, laying on a table, or going to your massage therapist, getting a body massage that you schedule.
So a more legitimate massage, like you're going for muscle treatment or something, massage, probably okay. Some of the more sexual, intimate massages that are available might not be a very safe thing at this point in time. Would that be appropriate? That an answer?
Yeah, that sounds reasonable. Yeah.
Yeah. Okay, so the next question is about low supply of vaccines, and considering that we have been through COVID, and you would think that we would have learned a lesson about preparation for a disaster. Why is there a low supply of vaccine? Did we make a big mistake, or what's any thoughts about that?
These are coming from stockpiles of smallpox vaccinations, something that had been claimed eradicated. We had not seen monkeypox very often in the United States, right? There were a couple cases of outbreaks, but none to this size, right? Like not as many populations impacted as previously impacted. So it was, pulling from, again, stockpiles, and there just weren't nearly the amount as what, again, the virus just outpaced supply.
So basically the stockpile was not really that big. We were kind of thinking of maybe a small event of spread, not anything this big, I suspect. But yeah, I mean, now in retrospect, we should have had more. But in any case, I think that, they are finding some ways of getting more people vaccinated. And in terms of vaccination with these drives that you mentioned, does the individual need a second dose?
To complete the series, individuals need a second dose, and often you can go to your public health department to be able to get the remaining dose.
So they can get the first dose at one of these events, but after that, they're going to have to go back and, get that second dose. So now, why has the World Health Organization designated this as a public health emergency of international concern? Anyone have any idea about how that designation?
This, first of all, it drives attention to being able to communicate risk, as well as to ensure that there's vaccine supply, as well as to start garnering international emergency funds to be put towards an issue when you call something an international or national concern emergency.
Right. Now, there's a question here about stigmatization and identifying this as a gay disease and so on. And whether you have concerns about that? I know that certainly during the time of AIDS, when that first appeared, a lot of people were afraid to even be tested because it might bring up issues about their sexuality. And I do wonder a little bit about if we define this as a sort of men having sex with men disease and not as just another infectious disease that anybody could get, whether that will inhibit people from getting vaccinated or treated or tested. Any thoughts about that?
I think this
Alexis, you want to go first?
Dr. LoVecchio, Dr. Colin and I were talking about earlier this week is stigma associated with certain infectious diseases. However, when one of the risk factors is men who have sex with men, not the risk factor of men of sex between men is one of the greatest risk factors for spread, for how the virus has been spread. Yes, there is that fear of stigma. We're also starting to trying to understand more and more about how the virus can be spread, right? And so simply limiting it to this is a virus only experienced, or this is an outbreak only experienced among men having sex with men would limit the other ways that it might be spread, and therefore kind of make us feel safer about other populations not being impacted, right? Like this population might not be as affected, right? So there is this fear of stigmatizing by saying this is a disease prevalent among a population who identifies as gay and bisexual. It might miss the risk factor of men having sex with men. But then also by saying this is a virus that only impacts this one population, it might overlook other ways in which the virus may be spread.
Good point.
I think
Anything you'd like to add?
Yeah, I think some people say you get this by close, intimate contact. And it seems like most of the outbreaks have been in that demographic, but certainly it doesn't mean that men who have sex with women or women who have sex with women are not going to get it. They'd be at the same risk. There's nothing about, the genetics of that population that would change it or anything. So it just has to do with the intimate contact. It probably,
and I think over time that probably we'll see that other populations of people will get this. We're at an early stage in this epidemic, and I suspect that it will spread to other populations, just like HIV did. Are there any long-term effects from having monkeypox?
well, I'd like to say that very, very infrequently you could die. So that would be considered a very bad long-term effect. But
Right.
Some people have gotten encephalitis. Encephalitis means like a virus goes into your brain and kind of could cause some swelling. And so that could lead to anything. You could become off, not yourself anymore, or even maybe things that look like a stroke. Those are very, very uncommon. By far, the most common thing is scarring. Those lesions are pretty ugly.
Yeah.
They go pretty deep. And then when they heal, they tend to scar. So they can be disfiguring. So that's the main.
Any chronic pain from this? That's one of the things that we see with the herpes zoster. Anything like that?
I don't know enough about that to say that. I haven't seen it in my reading.
Yeah, I think it's still probably too early to tell, but clearly something worth looking at. One of the questions about whether this follows a dermatome, and I believe the answer is no, but Frank, anything you want to say about that?
No, it's most likely to go to the place where you had the most contact. So if somebody had it on their shoulder and I had lots of contact on their shoulder, shoulder to shoulder contact, that's most likely where it would start on my body. And then I could spread it to other places.
And I think, again, in that regard, although we didn't have any pictures of the genitalia, that there are a lot of people who have presented with lesions in their genital area, rectal area, and so on. So, again, those are areas where we do see a lot of it.
Absolutely. And I
Yeah.
think related to some other questions, and maybe a question that's coming up, is it's commonly associated with another STD. So somebody might have that. And I think that if there's clinicians out there, I think you really should be checking the patient for HIV, gonorrhea, HPV, et cetera. So for other diseases that are transmitted in a similar fashion.
And Frank, do you routinely treat for other STDs when you treat for monkeypox?
If they have any inkling of any symptom, yes. So,
Okay,
and you know, we usually, as you know, we probably treat for gonorrhea and
right.
quite often. So those are pretty easy to kind of prophylax for. The other stuff like herpes, no, you wouldn't typically start them on an antiviral like acyclovir or not. But I think it behooves us to check them for HIV, and if you're not going to treat them for those other things, to check them for those other things.
Yeah.
I think it was like a third of the first round of cases at CDC, they had a second infection.
Wow. Okay, well, that's very important. Any other treatments for severe pain besides the nerve block that you described?
You know, the nerve block thing is, it probably didn't work all that well. And, you know, when we do that, it's kind of like you go to the dentist, you feel great, and then you feel terrible when you go home because the lidocaine wore off. You could use some longer acting agents. But you see people talk about all this other stuff, like there's a drug called gabapentin that anytime
Right.
nerves involved, people tend to give it. It takes you a couple days to get up there with gabapentin level to kind of get pain relief, and it doesn't work for everybody. So people are using things off label. And I never thought I'd say this, but I think it might make sense to give the patient opiates. And you know, if they don't have addiction potential or low addiction potential in the patient, I think it's one of the only ways you're going to relieve their pain.
Yeah, for the severe pain, that may be one of the only ways to deal with it if they really can't even sleep at all.
Right.
You know, so there's a question here about self-diagnosis, you know, people looking at pictures and taking pictures of their own lesions and maybe misdiagnosing this because of not really having the background. Do you think we should do more in terms of putting out tools to help people self-diagnose their own cases?
That would be a fun app to make. I think is that they're asking for an app. It'd be kind of fun, but I think at the end you should probably talk to a provider. You know, you could say, make a quick checklist, you know, what do the lesions look like? Or do you have fever, chills, the other things? And then it says, okay.
Yeah, I mean, particularly at the early stages, it can look like anything, you know, so it might be hard to make the diagnosis.
Yeah.
But yeah, I'm sure there is a lot of anxiety, and clearly if people want to get vaccinated quickly, they may, you know, look at some rash and want the vaccine right away. Let's see what else we have here. Anything related to respiratory spread through droplets? Anything you know about that?
Well, I have to say, I don't know of any cases of respiratory or fomites. Fomites, you know, when you go to, people say when you go to the toilet, you're supposed to put the lid down when you flush, and the fomites could be all over the place in the bathroom, and you can get exposed to those things, especially in a public restroom. I think those concentrations are too small. And, you know, people have estimated that, you know, you have to be right in somebody's face for a prolonged period of time, maybe to get enough concentration to cause that.
So less
very unlikely.
Okay, and last question here. If you're not in an intimate sexual relationship and are single, are you pretty much safe from monkeypox? Well,
the short answer is, assuming you do nothing else. What if you wrestle, you know, that kind of stuff, you're getting massages, but it would be very, 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 very unlikely to get it if you're single, not in a relationship.
You're lower risk for sure.
Yeah.
All
right, well, we're going to have to end, but I want to thank our speakers. This was really a very valuable session, I think, with new information about a new disease, and I certainly learned a lot, and I'm sure that all of the people who are on this did. So thank you so much, and we will obviously, if you have continued questions, our speakers are both faculty at ASU, and I'm sure they'd be willing to follow up if you have questions for them. So again, thank you everybody for participating, and we look forward to you joining us for our next health talk, which will actually be at the end of next month. I think it will be about treatment for veterans, and we'll give you more information about that later. So thanks again, and goodbye, everybody.
Goodbye. Thank you so much.